and we were doing osteotomies, and everything I tapped, a couple times, and it just shattered. That moment of like, oh my, this is really bad.
So hello and welcome to this episode of the Rhinoplasty podcast with me, Dr. Cameron McIntosh. We are working through the month of March, kindly brought to us by Carl Stort's Instruments. And it's quite apt that the World Rhinoplasty Day month is done by Carl Stort's, because they are like the World Rhinoplasty Instruments, as it were. So tonight I've got a very special guest. This man needs no introduction, the chair of Duke Plastic Surgery and the champion of the 2020 World Rhinoplasty Day, Dr. Jeff Marcus. Jeff, welcome to the show.
Hey, Cam. Great to see you. Great to be here.
Awesome, man. Jeff, so we're going to kick it off. We've got so many things to chat about. I just still vividly remember meeting you 3 years ago when you and Spencer Cochram came out to South Africa. It was a delight to have the two of you as our guest speakers at our second Saucer Congress. And I always remember whenever Stuart and I are operating, sometime during the operation, we'd be pausing and we'd say to ourselves, what would Jeff do? It's just like an ongoing little joke for us. Eh? And I can still, one of the things that stood out for me was, it's funny how rhinoplasty is this speciality with these tiny little things that change things dramatically. And I can still remember whenever I do like a turnover or turn under flap of the lateral crura, there's a tiny little corner that I remove. And I'll always remember your talk on that.
Yeah, that's important. You got to remember that corner. It looks really small, but it's a big deal.
Yeah. So Jeff, before we get into some of the nitty gritty stuff about rhinoplasty, tell us a little bit more about yourself. You and Jill married, kids?
Yeah. I'm living in North Carolina. Duke University is in Durham, North Carolina. And I live here with Jill, who you met and who says hello to both you and Stu. She thinks Stu has the most fabulous hair in all of plastic surgery. We have our two kids, Claire and Owen, and they're 12 and 8. That's our family. And it's crazy. There's cats, dogs, hamsters, and all kinds of stuff going on here.
And what do you do when you're not working at the plastic surgery unit?
Well, besides chasing around the kids, that's kind of the big thing. But trying to keep up with all of the things that they like to do. We recently got a home in the mountains in North Carolina where we've been traveling out to. It's out on a lake, and we're really just kind of enjoying getting away from time to time and going around and looking at the wildlife and just hopefully relaxing here and there.
That's great. And tell me, how did you end up getting into plastic surgery to start with?
So, yeah, I mean, my path, I was a medical student at the University of Michigan, and I definitely was not one of these, I wasn't one of these kids who just kind of always knew what they wanted to do. I started out and, I figured out it's one of these where generally people gravitate toward where their personality takes them. That's what I know now, and people said it at the time, but I didn't realize it. Happens that, I tend to be a rather impatient person. I like instant gratification. I don't like to wait for things. I like things to be very clear and evident. I like things that are either, very clearly successful or not. It turns, and I do like to use my hands a great deal and always had before. So, I was very open-minded about a lot of things, but it became pretty clear to me soon that surgery was going to be it for me, and started looking at things like surgical oncology. And I'd spent some time at the National Cancer Institute here in Washington, D.C. And I realized that, it was saving lives is one of the things that was, so fulfilling about it. But a lot of times you were taking things apart and making a big mess out of situations in the course of trying to save a life. And it could be very, from time to time, that would be also rather distressing, even when you did save them. And, the reconstructive surgeons in particular would come, and the job was always such a positive experience. They were always putting things back together. And it's just a feeling of positivity that went with that. And the technical part of it was so inspiring as well. So then, there was that element to it. Thought a lot about cleft lip and palate, and thought a lot about going into otolaryngology. And I had a couple of mentors one who was the chair of, at VNT at Michigan at the time, and he was a facial plastic surgeon, and also my mentors in plastic surgery. And then amongst everybody, once I really started coming, narrowing down a little bit, they were all great in terms of advising me what they thought a good path would be. And so I think that's ultimately what happened. As a kid, I had a grandfather who grew up in Europe, in Poland, and he was a tailor, and he taught me how to sew when I was 6 or 7 years old, something, and which I thought was completely normal. And we used to build like models with my dad, and using only I was in charge of doing everything that was tiny. Anything that was tiny was my job, and so painting little things and so on. So the thing, that's just where it happens. And so my life was gearing itself toward instant gratification, things that were very visual, things where it involved the use of my hands, specifically very, very small and fine and detailed things, and the more challenging, the better. So what does that describe? That's rhinoplasty.
Yeah. But no, I think it describes more than just rhinoplasty. I mean, within most of the people on this podcast are rhinoplasty focused, but you more than just rhinoplasty within plastics. What are some of the other passions within plastic surgery?
Yeah, so I started out, when I came to my present job in like 2002, coming out of Toronto at the time, where I was a fellow in craniofacial and then in pediatric plastic surgery. And so I was asked to build a bunch of programs to sort of emulate what they were doing at the hospital for sick children in Toronto, create these things, here that they have there. And being naive, I figured, okay, well, I'll try, and I can do that. And so I did. I mean, and I spent a good amount of time, really building up on the cleft lip and palate and craniofacial program, creating something that, was here, but not at a large scale. We did a lot of work in facial paralysis and reanimation in Toronto, and I was creating that program as well. So it's interesting because the circles I run, and it depends on who you talk to, what they think I do. Because, I spent a lot of time in the cleft and craniofacial world, and they have no idea that that I'm doing, rhinoplasty at any level. And they say, "Oh, I didn't know you do rhinoplasty." And I'm spending time in the rhinoplasty world, and people think, first of all, a lot of people think I'm an ENT. They don't really, some of them don't have any idea that I do any of the other stuff. So it's kind of fun. So I do enjoy the breadth and, a larger scope of things, and I've certainly pared it down quite a bit. It used to be even more broad than that.
So, Jeff, I hadn't known how much craniofacial stuff you did either. The other thing that I find so intriguing, and it brings me back to one of my first visits to Rod Roerick in Dallas, where I'd watched him for 2 weeks, where he is grinding and he's working early and he's editing the PRS and all this kind of stuff. And I in South Africa, in a way, there's a split between what we'd call the academics and the private practice. And after 2 weeks, I asked him the one day during a procedure, I said to him, "Prof, how do you find time for the academics?" And he put a scalpel down and he stared at me and said, "Cameron, academia is a state of mind." And this is what inspires me about you guys, is that this is the other thing. I mean, you're the chair of Duke Plastic Surgery, so it's a massively academic situation you find yourself in. How do you marry those two, of your clinical love for using your hands and working in all these different kinds of plastic surgery, and then at the same time having to run an academic department? How did you get into academia like that?
Well, I mean, I think, first of all, I guess I actually kind of agree with Rod on that, is that, and I tell my residents all this too, I say it a lot, is that it doesn't matter what the building looks like where you're working. To be an academic means to love to share knowledge in some way, or in any way or form, really. So, you could be in a big university kind of situation or tower, or you can be on a podcast right now like we're doing. So you are an academic. You love to teach, you love to share information, and you want to share it widely. And I was so, that's why I've been so impressed by, what you've done, not only with creating the society, but then with all of these things, the podcast, of course, but, creating World Rhinoplasty Day, and, all of the things all the webinars that took place even before that. So you're as academic as anybody I know. And so how do you manage it? So you basically partition your time, and somehow you figure out, you you have to try to marry things too, like you get some good synergy. So I'm going to spend my time teaching rhinoplasty to residents. Okay, well, while we do that, let's take a whole ton of pictures and let's talk about a topic, and then let's think about the cases, and we're going to write about it. And so we think about it, we spend that time, we create presentations, and then we ask a question and we investigate it, and now we have a paper, and then we have a presentation, and then and people are interested and they want to know what it is we do. So that's really like that's the thing that drove me the most, was just that desire to share the information, to teach with residents, but then, more globally. And I'd say the only, a difference, I have to deal with a bunch of bureaucracy within the university, and you have to deal with a bunch of bureaucracy in a business, in running a practice. But we're both trying to teach people about like what it is that we do. And that's just pure passion. It doesn't come from anywhere other than just desire. Because a lot of the things that you do and I do, you're not really being compensated for that. It's just why do you do it? I don't know, because I love doing it.
Yeah, exactly. Like it's now it's midnight here, waking up chatting to you, which is great. So
you're in the middle of the night talking to me. What are you thinking?
It's lovely because it's cool. Tell me, Jeff, can you remember a defining moment in terms of rhinoplasty in your career?
Oh my gosh. Yeah, I got a couple of bad moments too, actually. So I'd say, I'd say to start, when I was in Chicago and I was training at Northwestern, and there were two surgeons there that were doing a lot of rhinoplasty, and one was Tom Musto, and he was trained in ENT and then in plastic surgery, sort of dual boarded that way, and he was the chief of the division. And then there was Peter Mckinney, who a lot of the listeners may know and many may not realize, but Peter Mckinney, who was one of the founding members of the Rhinoplasty Society. He was private practice in Chicago. He was on faculty at Northwestern for most of his career. Probably best known for McKinney's Point, which is where the great auricular nerve kind of crosses over the sternocleidomastoid. So he had tons of really helpful publications. And so I always had one doing, closed rhinoplasty. The other one was doing open rhinoplasty, and going back and forth and trying to talk to them and understand, they had completely different philosophies. And I was fascinated by this. And I think probably the thing that was what got me probably the most at the time was we would going over the pictures prior to the case and trying to come up with the plan. I loved doing that, doing the analysis and trying to, challenging myself. Can I get this right? Do I really actually know what I'm talking about here? And I realized at one point in time that in some of those cases, I realized it might be better for me if I don't scrub. It sounds crazy. I would ask, can I not scrub this? Because I want to just take notes. I got to take notes. And so that was one moment. It was the moment where I realized that the operation is in your head. It isn't really in your hands. And I didn't know anything else that was like that, not to that level. All of the things that we do, whether things that you were doing in training and me, there were so few things that were that intense about the thought process, not just before, but during too, because you have to adapt as you're going a lot of times. Like you encounter things that you think you were prepared for every little thing, but sometimes you're not, and you have to change your plan. So that got me. The other one that was, I think it was more of the challenge and the humbling aspect of it. So why is this thing so humbling? Of course, I was always hearing people say, Jack Gunter used to say, if you've done 1,000 rhinoplasties, you're just beginning, or you're just starting, or, and, I've never done one I've never done one that's perfect, but I'm going to keep trying. He said that, like, just probably I was talking to him before he passed away, and he said it, I'm sure he said it a million times, but, I was doing something as a chief resident. It was a cleft rhinoplasty that I was doing with a mentor of mine, and, patient had some prior work done. It had also some trauma too. And of course we were in a situation where it was, we didn't have all the best instruments, I'll admit, at the time. And we were doing osteotomies, and everything I tapped, a couple times, and it just shattered. That moment of like, oh my, this is really bad. And, so of course I'd never experienced anything like that before. And, the person I was with didn't panic at all. And we actually, we carefully had managed to pack gradually, piece by piece. We packed it inside and then compressed on the outside, and managed to get things into, appropriate position. And I continued to follow that kid for about 6 to 10 months. And I was shocked at how good things actually turned out. So moral of the story there was, it's an operation that should be respected, and it is challenging and humbling to anyone. It should never be taken lightly. And that also that, there are solutions to most problems. And you just have to keep your head in the game. And in most cases, you'll be able to figure out a way to get through.
Yeah, that's fascinating. I think one of the things patients don't always understand is that people can often see good results, but they don't realize that behind the scenes, that's the whole point of being board certified and trained, is so you can deal with the complications. When things go wrong, who do you want? It's not the guy who's there when things go right. It's when things go wrong. That's the person you really want on your side. And I often will say that to patients. Every patient I see, there has to be that trust from both sides before we'd even consider wanting to do further surgery, because it's so complicated that the 3D look of the nose, and here we are, operating right in the center of the face. So, rhinoplasty, I think I love it. We've got to respect the operation massively.
Yeah, I think it's like I kind of taken off on one of your points. I was just talking today. I saw a bunch of patients today in clinic, and one of the lines I often talk about, I tell them that, I have a job here. I have something that I need to get from our conversation, and you have something that you're needing to get. And for me, I have to understand what it is you're hoping to achieve here. And I have to see if I understand all the things that concern you, and if the things that you see and that bother you are the same things that I am noticing, and that when I'm looking at you and observing, and if I feel that these are things I'm capable of helping, then I know that I'm going to be able to at least offer to you, what I can. And from your position, all this is that you have to be able to look at me and think I'm not crazy, and I trust this person to actually carry out what he says he can do. So if you feel that I don't seem crazy to you in what I'm about to tell you, and trust that that I can help you, and if I'm honest with myself, knowing that I feel good confidence about being able to help what you're hoping to change, we're going to be good.
So Jeff, one of the things that you've sometimes mentioned in your talks is like a surgical toolbox. I want to take it a step further and say, I think in many of the webinars, we've been teaching colleagues about surgical tools, but there's this massive part of pre-surgery and post-surgery. So what I'd like to ask you is how, in all three of those aspects, before you even cut the skin, when you're doing the operation, and after the operation, how over the last 2 decades or 3 decades that you've been doing rhinoplasty, has that changed for you? Which new tools are you using? Which old tools are you not using so much? I know within the surgical side, I'm quite interested to talk to you a little bit more about piezo. But to kick it off, the difference between the Jeff Marcus now compared to many years ago when a patient comes to see you, what are the big changes in that pre-op consultation?
In the pre-op, okay. First of all, I don't look like I'm 12 anymore. That's helpful.
You look like
that's
you're
helpful to gain
now.
trust. Yeah. I'll tell you, getting full folks who are older to buy in when you look like you're just graduating college or something, that's tough. But so I look a little bit older. That's helpful. I'd say, first of all, the confidence level is there, and there isn't any way to turn that on in earnest. You can you can pretend and you can put it on, but really with time and with experience, your confidence is there, where you can say, and you look at something and say, yes, I can tell you, I've seen this a bunch. Yes, I've seen this a bunch of times, and this isn't unusual. You're fine. It's absolutely normal, and we're going to be fine. I know exactly what to do. Let me show you what it is. Spotting things right away, and that sort of confidence. It really puts people at ease and makes the whole consult go better. I think so. That's one thing. So the way you carry yourself is, I'd say that's one way that things have changed a lot. Learning how to talk to people in such a way that you can engender and gain that level of trust. So when I walk in, I've learned at this point, I don't start talking about anything related to the nose for like at least, I don't know. I mean, at least until I figure out where are they from, what do they do? Do they have kids? Where do you work? What do you like? I like to talk about who they are. And then by the time I say, well, I guess you're here probably to talk about your nose, right? I think my nurse was saying, and she said that you mentioned this and this, and they say, oh yeah, okay, well, great. So learning how to approach somebody and to talk to them and look at them and make them, understand that you actually do care about them as a person, and you're not just trying to book the consult, So rushing through is not a good idea in rhinoplasty. It's not really a good idea in anything. And I realize it's hard. Rhinoplasty is not an operation that you can just turn over quickly, where you can do, assembly line type of an approach. It's hard to do it that way. You have to, it's helpful to connect with people because as what I was saying, like as Jack Gunter said, he'd never done a perfect nose, but he was going to keep on trying. The same is going to be true for me. I should know that. So if there's going to be something that's an imperfection afterward, and maybe the patient may notice and maybe they don't, but if they do notice and there's something that's imperfect, if your relationship with them is good, then you'll be able to have a conversation about that problem, and they'll trust you when they say it. And I'll tell them, even if you ever have a problem or if you ever have a concern, I just want to let you know, please never feel afraid to mention it. You can tell me, because I promise you, I already saw it.
Well, that's amazing.
I'd say that's
yeah.
So I'd say that's one, is so having how to have that conversation so in the pre-op and putting people at ease and creating the rapport that's there. And if you don't have that, as Mark Constantian says, that is, you got to know when to recognize, and we can get into that too, all of the things that are the warning signs about folks. Another one would be, I think, the analysis. I was very resistant, and of course the technology changed, but I was resistant to morphing for a long time. So photo manipulation and simulation. In part because I was seeing it being used initially for a long time. I thought it was being used as simply a marketing tool, and I believe it was for some. And they could, where folks, surgeon can do, quite a lot on the computer, and maybe, it was it was a useful way for them to book the case, basically to turn over that consult. And, because the patient can look at that and be like, okay, well, great. That's what I want. I'm in. The problem is that sometimes I don't necessarily think people were always being realistic. That was one. And of course, you can write as many disclaimers as you want on there, but the patient has seen it. Once they've seen it, no disclaimer counts that out. That's what they expect. And that bothered me a little bit. I was afraid that people may, their expectations, may not be in line. And then also some of the technology, even at the time, was just unwieldy. It was just, my God, it would take I'm going to spend, 40 minutes just messing around on the computer, because that's what it would take to use what we had, at that point. So I was pretty resistant. I was using, full size images, printed images, and drawing on them. And I still do a lot of drawing. So I think where I am now is that I blended in. I still love to draw. I still love to use the hard copy photographs. I still like to do diagrams saying this is how it's going to be done, because I'm a nerd about rhinoplasty, just like I know you are. We like to nerd out about this stuff. And some patients enjoy that piece. But now I've incorporated some of the simulations are so easy now, and you can do a few simple things. And if you're honest, and what I notice is that I don't even take it to the point where I would really like it to go. I go a little shy of that. I'm just going to go a little bit better. And then they say, yes, I love it. And I'm like, good, because it's going to be better. And in my head, I'm thinking it's going to be better than that.
Yeah.
So if you like that, we're fine.
That's cool. Wow.
That'd be my pre-op.
Yeah, that's very interesting. You can't buy experience, and that's what years and years of experience brings you. Okay, so tell me about your surgical toolbox. Which tools have now moved further down, and which tools are new or have moved up?
Yeah, so this is one where if you go back to when I was starting, there was a lot of the arguments at that point. The closed open argument was still very much in effect. And of course, we've practically gotten past that now because it's clear that there's a place for both. And now that might be a matter of preference. Some people may choose not to do one versus the other, but there's definitely a place for both. Same surgeon might, decide in certain instances that they prefer to do one or the other. And I have total respect for all rhinoplasty surgeons who are able to get great results no matter how they can do it. I don't care how they get there. It's a hard operation. If you can get a good result, I respect you. So I think we're beyond that. And I think the tools at that time were also very crude. So we were doing at that point, I don't say crude, but for example, every patient who had an open rhinoplasty was said to need a columella strut. If you do an open rhinoplasty, you're destabilizing the tip, you need to have a columella strut. Not only that, it better be really stiff too. So sometimes we're going to need to put a K-wire in that columella strut, and we're going to put it into the anterior nasal spine because we thought that it needed to be that. Or we would put it all the way down onto the spine or very, very close because we thought it needed to rest there. But then they started clicking back and forth, and the patients would come back and they say, "Why is this thing clicking here? It's driving me crazy." So, that was something that was pretty ubiquitous actually in the open world. Of course, now, we've come to learn that there are other ways to do, to get projection that don't require that. I mean, and there's, pros and cons for the new things too. And I can mention I'll get to that part in a moment, but then spreader grafts also were something that were pretty widespread at the time for good reasons and many, for functional reasons. But, as things go, there's always enthusiasm that hits a big wave. And then we realize that maybe we're applying these probably a little more often than we really need to, because it's a very useful tool, but does it need to come out of the toolbox every single time? Same with columella struts. Do we are we never going to do them? Not a never. It's just, we're going to pick and choose maybe. We're going to add some new tools into the box now as the years go on, and we learn of things, and some things are very esoteric and we confuse the hell out of learners because we keep introducing things that are like minutia and esoteric and kind of just maybe useful in a particular circumstance or not. I think that's the way I've always looked at it, is I'm collecting tools as I go in the box, and I'm realizing which ones are the most useful things and which ones are not as useful, which things come out a lot, which are used for specific circumstances. And I think that's why I teach my residents that, certain things are in the top shelf of the box, and then there are certain things that are in that bottom bin. And so they'll say, what is this thing I hear about? And they'll mention, a little technique, let's say there's a useful technique like facet grafts, or like a little, there's little butterfly grafts that help, for the infralobule. Well, it's a very cool technique. It's very nerdy. I love it because I can see where that's helpful. Ash Gavami and some other people, they ask me about that. I go, listen, that's going to be in the bottom bin of the box, and it's useful for some specific circumstances, but that's not, the success of your operation isn't going to depend on that. The success of your operation is going to depend on on the big things, the main things that really are, that lead to, success versus failure. Those are and the tools you're going to use for those are going to be on your top shelf. You're going to use them a lot. So you got to get projection correct. You got to get the right amount of projection. You have to get the right amount of rotation, and you've got to get the dorsum proper in its position and shape and, and prominence relative to the tip. If you can do those three main things, the rest of the other things will be relatively small. Doesn't mean, they're not important. It's just that they are not going to lead you into like a major revision.
No, absolutely. And what are some of your opinions on this new kind of debate that seems to be raging between preservation and structural rhinoplasty? I think, but it might be quite controversial to say, I think there's a lot of it's to do with marketing. Rod Lowe saying everyone's world famous on their own website.
Yeah. Well, so I'll go back to kind of what I was saying a moment ago, is that if a surgeon can achieve a great result, to me, I don't really care what it is they're doing if they can do it, if they're getting that great result, because I'm going to want to understand it. I may not be able to pull it off or do it because I know that it isn't a part of, it's not a part of me at the moment. So I don't want to discount it. I do want to hear about it though, and analyze it. I want to see if what they're doing, if what's being done is better, easier, or less risky than what I'm doing. And so and I'm not there yet. I haven't figured it out yet, but I will share that I've seen some phenomenal results. My friend Lauren Rosenfield, who's in San Francisco, is a great aesthetic surgeon and teacher, always says, he always gives caution to, the shows that sometimes we as surgeons put on, because, we don't always show our problems, and we don't always show the bad outcomes or those, those kinds of things. And so that is not me saying that I believe that those bad things, that there are bad outcomes that we're not hearing about, but in time we'll learn a little more about what kinds of pitfalls are there. What are the cases you don't want to do it on? How do you fix those? And that's where I'm not quite there yet. And so I don't know. I mean, I don't necessarily think it's a point of controversy, because right now it's a matter of preference. The fact that they're able to, that the proponents are able to generate so much enthusiasm for it, well, sure, that does actually bring a lot of attention to them as surgeons, for not only in the community as teachers, because they're packing lectures with these with that subject, because people are dying to hear about it, and that's great for them, and their patients are paying attention too. But I think that over time we'll figure out what's the place. I was talking to Enrico Rabati about it, and he was giving some of his thoughts about can we incorporate this or not, and I'm thinking about it, but I'm not an old person, but I've been doing this for about 20 years, and it is hard to make a big change like that, and so I have to figure out, like, if I want to try, when am I going to take that chance?
Yeah. And
what do you think? I mean, are you going to give it a go?
So, good question. My greatest way I've learned rhinoplasty is by visiting surgeons around the world. And there's always a lot to be taken out of a congress, which is more like, in a way, an academic thing. Someone gets up there, they give a lecture, great lecture, etc. But nothing beats being with somebody in a clinical situation. So literally sitting next to somebody when they're interviewing the patient the first time, or standing next to somebody or assisting them in surgery, because that's when the mistakes happen. And you think to yourself, how? Like, a guy would be on a tertiary rhinoplasty and he's busy dissecting the nose, choop, goes straight through the skin. Oh, no, don't worry, we'll just suture up. And I was like, this is amazing. So my kind of journey with so I've watched Miguel. He operated with us a preservation case 2 years ago, but I haven't had enough time on what I would call the clinical side. So on the academic side of understanding and listening to the lectures, etc., sure, I'll tick that box, and I think that it's a great idea. But I'm not comfortable enough yet, because it's my reputation. I have to be able to prove to these guys that I know what I'm doing if I'm going to operate.
There was one to that point. So I did the same thing, and I wish I could do more, by the way. And if for people who are listening, especially if you're early on, and if you have an opportunity to go spend time with people directly, definitely I would urge you to do that. I did go out with there was one individual I went to see at one point, and who was doing something that was rather new, and also I guess had some controversy to it as well, and also there were some comments about it being used as a marketing situation. But I wanted to see it, and and there definitely was a lot to learn. I'll tell you that, because just as you said, it's never quite exactly what you think it is. And I think at its worst, there were points I thought, this is a mess. This is just a mess. I'm like, this is not what I thought at all. So yeah, I think there's something to that. And that's not to say that every new thing is a problem. It's just, be careful, about judgments, I think. So we're talking about new ideas, new techniques, and controversies, and the role of the value in visiting people. I was just saying that I could not agree more. I think it's really, I wish I had a chance to visit more people, and I think I probably will try now. I do think if I end up doing some work with preservation, I probably would go out and visit with Sam, in part because Sam and I are really good friends, Sam Most in San Francisco, in part because we're really good friends, but also because his take on new ideas is always slightly different. He always has a slightly different way of looking at it, where it's a little bit more pragmatic. So that's kind of the thing. He thinks about it for a while, and he thinks, well, I like that. I think it might be helpful, but I might be able to do that safer if I do it this way.
Yeah, we had a very interesting talk last month with them. The one thing also in the surgical toolbox, which is also new, is the whole piezo side of things. So I'm just kind of dipping my toe into the ocean, and I'm enjoying it tremendously.
So here's the big question, and this is really the decider, because there is, in my opinion, like there's no doubt that it is absolutely useful, and I've played with it, and there's so many cool advantages that it offers. The big problem is this in the United States, and this may not be true elsewhere, and it's probably not true in private practice in the United States, but when you work in a large institution in the United States, and if the package says single use only, then it's single use only. You can't re-sterilize it. And one of the biggest, like, I think values with piezo is that you can have a number of different working tips. And Olivier created, I don't even know how many, Olivier Gerbol, who created, I think there's maybe 10 or more on that small set. And, one's for scraping, one's for burring, one's for cutting, one's for drilling. And they're so useful. And I did visit with him once too, and watch, in a particular case, where I'd say he used at least 4 or 5 different ones for different purposes during the case. But the problem in the US is that every one of those says single use only, and I'm at an institution that reads the packages. And so they just won't allow that. And so I can't, and if I can't charge, I don't even remember what it is now, $250, US for one of those tips, forget it. I can't add that kind of cost onto the case. Whereas I do like power equipment, so I do have micro saws and micro burrs, but the tips are $25.
Exactly. Yeah. Okay, Jeff. So let's talk a little bit more about your post care toolbox. How things have changed. Because this, I think, is where the mistakes that we make really change things for us. And what's changed for you over the last 20 years? Not a lot, to be honest with you, in post-op care. I've always had kind of a ritualistic sort of a way of doing things with taping, and probably some of what I do is even unnecessary. So taping and splinting and use of internal splints, probably I'm doing more often. Anytime I'm doing work with the turbinates, I'm going to do something to keep them out to the side and hold the septum straight in the middle. I think that those are helpful. We didn't have those when I started. So channeled splints, like Doyle splints, they actually weren't available. We used to cut, we used to take plastic milk jugs and cut this, it was thin, flexible plastic, and they would cut them to be, the proper size and shape, and then we would sterilize them. And that's what we used. And then they came up with, with Doyles, which are great for when you're doing turbinate work. Being mindful and I'd say maybe more vigilant about hematoma, being when particular phone calls, I'd say if a patient, there are particular buzzwords that a patient might call and say, when I know you come, that word, if that word's used, you're coming in no matter what. So anybody who says that they've got a funny smell, my office knows, funny smell, come in now. Just the way it is. I see something full. I see something in fullness inside my nose. Come in now. I see something full in my nose. So I think being a little bit maybe vigilant and just with experience, kind of maybe what things need to be addressed right away. And pain.
Well, how about you? What's that?
Pain. If a patient is
pain.
Yeah.
I definitely found that you need far less pain medication than what I used to give. Alternating doses of over-the-counter pain medication can completely, can not in all cases, but it can nearly eliminate the use of narcotic pain medication. And I have not used the liposomal bupivacaine, Exparel. I haven't used that yet, but I have been able to get close to limiting the narcotic use. How about you? What do you think the things have changed the most in your practice?
Good question. My practice hasn't been as long as yours. I think I particularly like post-surgery, I think it's kind of empathizing with patients more, to walk them through and explain to them it's a major like emotional surgery. It's that day of revealing the nose. It's almost change of personality sometimes, because it's a big thing. A lot of patients have spent years to get to the point to finally make the leap of having it done. So I often try and almost overplay saying what a change it's going to be, because it can. Some people don't care, but there are a lot of patients who it costs them a lot of money to get the surgery done. They really want great results. And the bulk of the patients like that, I love being able to walk that journey with them and say, listen, anytime you come back and you carry on coming back, and some people love that. Other people, it's just once and you never see them again.
Yeah. One thing that actually makes me think about something too. So there is another aspect to it I think that has helped me a lot. And that is trying to anticipate what's the specific questions that the patient or anxieties that they may encounter, especially given whatever their particular problem is. So I try to tell them ahead of time, this is what you may find this or think this at this time. And I need you to remember what I'm saying right now, because at the time you're going to wonder to yourself. For example, you have a teenager, somebody late teens, early 20s, and they have a bulbous tip, mildly bulbous tip. And you are going, and let's say that's the majority of the problem, and you know exactly what to do about that. You have to prepare them for the fact that the nose early on isn't going to actually necessarily even look any better than what it does now. And you have to make sure that they can understand, and you can tease them and kid around them and say, I know you're at 19, you're not exactly someone who's probably really super interested in waiting, but this is not instant gratification on this particular one. It's going to take some time. And I promise you, you're going to think that it's going to be swollen at first, and you'll be able to accept that. But when it gets to be about 4 to 6 weeks later, at that point, you're going to think to yourself, it ought to look the way it should now, because it's already been 4 to 6 weeks. But I promise you, you're going to get to 4 to 6 weeks, and you're going to look at it, and you're going to think to yourself, I don't think he did enough. But when you think that, remember that I told you at 4 to 6 weeks, you are going to think that it might not have been enough. But if you just wait it out longer, you're going to see that it's going to get better. And it starts out, that's where you have somebody with, a more subtle problem. But there are problems that are, the bigger problems, the more obvious problems, the structural problems, big dorsal humps, significant width discrepancies. Big dorsal hump and significant width discrepancies are instant gratification, and you can tell a person there's a very good likelihood that you're going to like what you see in this area very, very soon. But let me tell you here's some things that you're going to have to wait on. And if you listen to me right now, when I tell it to you, it's a prediction, and it's guidance and it's advice. But if I explain it to you later, then it's an apology. So that's why I'm going to tell you now.
Very interesting. So coming back to what you asked me there as well, the one thing I think probably the biggest tool for me post-surgery is I'm taking photographs throughout the operation for my own learning experience. But also what's been great is that gets put into a PowerPoint of maybe 20 slides, which is every step of the operation. So patient will come in, I'll remove all the bandages, take all the sutures out, clean them up, and we sit down, and then we're going to go through. So first go through the Gunter diagram. This is what I did. Now let's look at the photographs. And Jeff, patients just sit there with their mouths gaping open, because they normally used to only seeing only a few stitches on a columella, for example. But now you've actually shown them step by step. And then what I also have done is that's in a PDF document. So I'll email it to them. And it's great, because the patient actually feels they've actually seen so much more, because they don't think that you're spending 2 or 3 or 4 hours doing such intense surgery that you've trained for 20 years for. They just see a little result. So I've really enjoyed that very much.
I think that's kind of fun. I have never done that, but I would, especially for the right people. I mean, some of my patients, I feel like they'd pass out, but there are probably some that would love it.
Yeah.
I used to take, and I was taking actually, I still do sometimes. I used to do a lot more, like what you've said. I used to do a lot more step-by-step photos because I was, trying to prepare a lot of talks and teaching and then video. And I was taking a lot of, full-length videos on cases, and and then I would think afterwards, okay, was that one useful? And then so I would either keep it or not keep it. And from there, I've been able to create kind of a catalog of basically in my mind. It's not, I don't have it in mind to create some sort of a repository or atlas or something, but I have a file that I keep that says it's a toolbox. And so all of my every little trick, all the little tricks are in the toolbox, and I edit those videos, and sometimes I even annotate them and so on. And it's just that's been more of a hobby, just to keep keep the toolbox there.
Yeah, that's great. So we opening a new surgical.
I use it for the residents a lot.
Yeah, so I think that's one of the things I love doing is, so if we traveling and operating elsewhere and my normal cameraman's not there, give it to the resident, because they need to learn. And this is what Faisal of Payden showed me so much. If you can take good photographs, you are thinking from a surgical perspective, because the photograph is to teach other surgeons. So start off by only taking photographs in the operations. You're not scrubbing up, you're not observing, you're taking photographs. If you're not making notes, like you said earlier. Yeah. So we're hoping to open a new surgical center in about 3-4 months' time, and we're going full out to video everything. So we'll have like 5 video cameras in each surgery with a guy sitting, and he can edit it, etc. But I think that's the next step, from having photographs to now actually live recording each one. So I'm excited for that.
Let me repeat what I said earlier. You are an academician, my friend. You just the fact that you would think to do that, that's what a teacher does. You have 5 cameras. I mean, my goodness, I don't even have a video cameraman.
No, we're not there yet. We hope so. We hope so. And that's the lovely thing about chatting to so many of these guys is everyone has something to add. I mean, this has been now what we've been speaking for more than 40 minutes, and there's so many little pearls that have come out of here. So, yeah, Jeff. So let me try and think. Well, what else I want to ask you? I mean, it's an opportunity to speak to the world champ. Tell me a little bit about World Rhinoplasty Day. How was that for you?
So that was interesting. So I mean, I'll give you the perspective of a participant's perspective, because you were immersed in it as the planner. So at first I thought it was crazy. I figured these guys, what in the world? They're going to do 10-minute talks, 100 and some, I don't know how many were there, 140 talks, something like that, all 10 minutes long. I looked at the list of the names. You got teams from all over, they're creating teams, so they're creating like a competitive vibe here. And I'm like, oh, this is kind of interesting. I'm like, okay. And then, first, of course, I'm like honored, that they asked me, or my, US, Jay Calvert asked me to do it. Of course, Jay's a good friend. And I was like, oh, that's nice, Jay, and I'm excited about this. It's Cam and Stu, should be fun. And, then the thing starts going, and I'm like, my goodness, this is like a production. This is like a telethon on network, network TV here. And so I'm watching some of these presentations. I'm like, wow, that was really good. And so it took me a while. I think until the actual day of, I didn't realize, how large scale, it would be in terms of its production. And, I got asked to give a particular talk I was asked to give for the topic. I didn't choose it. And they really wanted me to create something that was, new. And so I thought, okay, well, I'll give it a try. And so I created something, and I hadn't shown it to anyone, other than, I don't even think my wife saw it. She always comes and peeks in here and sees what I'm doing. I don't even think she saw this one. So I figured, okay, well, I'll just wing it. I'm watching all these very, very, highly technical talks where for me, it was great because I'm taking some notes. I'm like, ooh, I like that. I'm learning some things here. And, mine, I figured, well, mine's not technical. It's actually has more to do with what you and I have been talking about, or a lot about patient selection. So we haven't gotten into that really, but it was about how do you, keys to having success and patient selection and planning and pitfalls and that sort of thing. So I figured, I hadn't even considered the fact that, that there's some competition in here and that maybe I might be able to do well in it. I just figured I'd be the boring talk, because I'm not technical. And so I do the thing, and it completely took me by surprise. Like when you guys were calling, I'm like, you're like, hey Jeff, they liked your talk. I think you're going to be in with the finalists. I'm like, what? I'm like completely, floored by this. So, and you're like, yeah, and you're going to be on camera. And of course, I don't remember what time of night it was at that point. So of course, I had to go get dressed. So I didn't want to look like a fool. So I was shocked. I'll put it that way. I was shocked.
Oh, no, it was great. So we had the editors of all these big journals, and it was really who was going for second place. I wasn't a part of the judging, as it were. I mean, I had to just kind of overall look after everything, but it was cool there.
Yeah.
Okay, Jeff. So last little point I want to ask you. I mean, we can talk forever, but how do you think COVID has changed things dramatically, and it's especially changed how education in rhinoplasty has happened with this plethora of webinars, etc. I'm concerned in a way that webinars, it's not giving enough practical training. People are going to get a lot of information from the webinar. How do you foresee us over the next while trying to adapt how we're going to be teaching and practicing rhinoplasty because of what's happened with COVID?
Yeah, wow, there's a lot there. Okay, well, I think, first of all, I do think that there is value. And I think that because it's such an immersive topic, and, we were talking before about it's so much is in your head that, filling your brain with a little bit more here and there, especially if it's things that are maybe a little different. So if you have access to some different thoughts and ideas that you would not have had access to otherwise, and it's easier for you to see it and get to it, that's probably a good thing. So, and because some of it you may just completely say is rubbish, and then others you might say, "Ooh, I never knew that. I wouldn't have thought of it." So I think the access to different points of view and different thoughts, that's good. And so I hope that webinars continue so that we can get access to these international people. You and I are talking here in South Africa. I mean, like, I can hear you like you're next door. And so this is great. I think your podcast is great. Like, so, hearing like this is an easy way to get the real deal from somebody. If you want to know, like, what's actually going on in a format like this, it's hard to, bullshit and lie. Am we allowed to swear on the podcast?
Yes, 100%. I love it.
Oh, good. Perfect. Bullshit. Yeah. So I think that's good. The in-person learning is going to continue to be, important. Not only just from like we talked about visiting, and I still believe that's good. But one thing you can't replace in these is that when I would go to like the Rhinoplasty Society meeting, and I would park myself, I would always, often I would sit next to Roland Daniel. I always go up toward the front and try to get next to him, because he and I would just start, somebody would be talking and we'd be drawing, and what the hell is he talking about? And we're like, what's he, and we'd go back and forth about it, and try to figure out like what these people were saying. And then we would talk in between, and then we'd get a few more people around and be like, did you understand that? I'd say some of the things I learned, some of the most important things I learned were in those formats. And you don't have to sit with Roland Daniel. You can sit with anybody, a couple friends. And, when you're done, you can try to dissect out what it is that was presented. And I think that's helpful. Clubs, like, there are travel type clubs and things like that. And, we don't have so many of those things anymore. I know I did spend a little bit of time with the crazy, rhinoplasty research group, the European guys, Olivier and Yves Savon's in that group, and Roland's kind of in there too. And George Marcel was there, and, Milos, who's completely nuts, Kovacevic. I think those travel groups are pretty cool. People who spend time together and, sort of geek out about things. Where COVID's going to come in is that I'm hoping that the travel part will come back, but that we'll keep some access to the web-based stuff too. Awesome. Has that been what have others been saying too? Is that roughly what you're hearing?
Yeah, I think people are desperate to meet in person again. Yeah.
Yeah.
So I look forward to coming to America again.
Yeah, like, so for example, to do a visit, I would love to go to South Africa right now, and I'd love to have you come here, but neither of us can do that.
Yeah. Jeff,
and then going to Europe.
It's been so interesting talking to you. What I was trying to tell you, it's inspiring. It's really great. I think to be a committed family man, kids, running the academics, operating like you do, not just rhinoplasty, man, it's fantastic. And I think the cherry on the cake is that you were the inaugural winner of World Rhinoplasty Day, man. And yeah, I appreciate the fact that we can take an hour of your time to chat about these things. And I think the listeners, it's good to kind of climb into understanding how somebody who's at this level works. So I really appreciate it. I appreciate your vulnerability. I appreciate the stuff we spoke about. And I hope that you have a great year in the department and family and all that kind of stuff. And I really hope that we can get you to South Africa soon.
Thanks, Cam. And I just want to again say thank you, and also to commend you on this project. I really believe in it. I think you're doing great work with this. I do think it's really valuable to bring people together. And I am very eager to support you in any way that I can in all of the works that you're doing. I really am impressed. So thank you.
Thanks. So this brings us now to the end, and I'm now going to be able to tell you guys who've waited so long about Karl Storz that you can get a discount if you send an email to this email address and ask them. And then you can be able to get some of these cool instruments to use in your surgical toolbox. So you need to send an email to, this is it. It is s.mazibuko@karlstorz.koza. So let me spell it out for you. It's s.mazibuko at Karl Storz, which is KARLSTORZ.co.za. So s.mazibuko@karlstorz.co.za. Send them a message. Karl Storz, thanks for your support. And Jeff, that brings us to the end, eh? I'm getting back into bed now, and I'm sure you'll be heading out that way soon.
Thanks again, Cam. Have a great night.